very much and take care.
Thank you very much. Thank you. Thank you very much, Professor Ahmed. Thank you. Now we come to Dr. Mona Azzam. Dr. Mona Azzam is Associate Professor of Pediatrics, Houston University, and academic staff for ABLS program, Hospital for Sick Children, in Canada, and course director at McMaster University in Canada. And her presentation today is about bubble and pitfalls in pediatric emergency care. The floor is yours, Dr. Mona.
Okay, thank you very much, Dr. Selma. I don't have one huge topic for today. I have just, hopefully, if we have enough time, 3 different puzzles that have recently been seen. So I'm going to start with just a quick introduction. So in a perfect world, the pediatric emergency department, you're thinking a lot of cute kids, so all of them cute, cuddly, and you can just have a good time with them. You also expect a lot of thanks and people telling you great job. And of course, sometimes you're interested in some extra money. But the harsh reality is you work very, very hard in the pediatric emergency department. You have very high stress levels, and there are so many pitfalls. So we're going to start with our first case. So this is a mom who comes in and says, my baby just turned blue at home, right? That means your stress level goes straight up. You try to get some more information. So you find out that your patient is a 2-month-old brought in by the EMS, by paramedics for an episode of possible cyanosis at home. The mother says that the baby was sleeping. Then she noticed the breathing becoming a little bit funny. The baby appeared to go limp and pale and blue in color. The mom stimulated her. She returned to normal in about 20 seconds. So a little bit more history. The patient was born at 38 weeks gestation, normal vaginal delivery, no complications, and has been healthy since then. She's had no sick contacts, has been feeding, urinating, and stooling appropriately. The baby's vital signs are within normal limits. She's alert, moving all extremities, and cooing on your exam. So I know we can't have a poll here, but I know a lot of us are thinking this is very concerning. We need to have a really important differential diagnosis. I don't want to miss anything. This is just a 2-month-old. And these are some things you might be thinking of, right? Was it a seizure? Is this early sepsis? Is it Brewy, Alti, near SIDS? NAI is non-accidental injury. And we'll talk about what these mean in a little bit. So that would be on your differential diagnosis. That's just 6 of maybe 100 possible differential diagnoses that you'll be thinking about. Interestingly, this case is actually Brew. So going back to this, so Brew, I know it initially a lot of us will pronounce it Brewy, but the correct way for it to be pronounced is Brew, just like you're brewing something. So what is Brew? What does it stand for? So the B is for brief. So it's less than 1 minute. R is for resolved. So the episode is now resolved. It's not ongoing, which means our physical exam is normal. Unexplained means it's a diagnosis of exclusion. So we've ruled out any other possible causes. And again, most of the time, this is just a history and a physical exam. And then an event. So what does the event include? At least one of the following. So central cyanosis or pallor, absent, decreased, or irregular breathing, a change in tone, either increased or decreased, an altered level of responsiveness. You don't need to have them all, just one of them. In addition to that, it's usually in a baby who's less than 1 year old. So if it's older than that, Brew does not apply. And again, making sure that you cannot find an explanation. So there's been a history of reflux, for example, and this has happened several times, but maybe a little bit milder. That does not mean that it is Brew. You could maybe go and more towards the diagnosis of GERD. All right. So those were the inclusion criteria. What about the exclusion criteria? So just the opposite. If it lasts too long, if you have any of these as you assess your patient, right? So any fever, any tachypnea, ongoing irregular breathing, anything wrong with the vital signs. And the cyanosis should be perioral acrocyanosis or rubor. Rubor is that like purplish blue color. And if there, as we mentioned, if there could be any other explanation. So those are exclusion criteria. So many of us may be more comfortable with the term ALTI. So we've been hearing that for a while. So the original term ALTI was developed in 1986. And remember, at that time, we thought it was something new. So it stands for an apparent life-threatening event. And it was defined as something that was just frightening to the observer. And it could be a combination of any of these: apnea, color change, change in tone, or choking, gagging. Eventually, it was separated from SIDS, which is sudden infant death syndrome. And it was just observed subjective criteria. So it included everything. There was no exclusion from it. Whatever the cause, it was always called an ALTI. So a systematic review found that there was a pretty high incidence of them. So 0.6 in 1,000 live births, and a little bit higher for all emergency department visits, less than 1 year of age. So it's pretty common, but again, because it was a very vague, subjective diagnosis, it included many other diagnoses. So because of the challenge that posed, the American Academy of Pediatrics in 2016 replaced ALTI with BRU. And again, just to clarify, the life-threatening portion is taken out because it's life-threatening is very subjective. So now we have very clear criteria for that. And again, you have to have excluded other causes. There's a strict age limit for BRU versus ALTI. And once again, it's a diagnosis of exclusion. Plus, the description of symptoms is more specific in BRU. So the color change can be pallor, can be central cyanosis, and that's how they would qualify. All right, so once you've identified that you have a patient who came in with BRU, the next question is, how serious is it? So a lot of patients are at low risk. They've had that frightening experience that the parents have noted, but to be characterized as low risk, these are the criteria. First of all, an age more than 60 days, gestational age more than 32 weeks, the first BRU occurrence and it's not recurring, duration less than 1 minute, no CPR was required, and no concerning findings in history or physical exam. So that would be low risk. The advantage of diagnosing a patient as low risk is you will, according to that, not need to do more intensive investigations. You can monitor the patient, make sure it's not recurring, educate the parents, and then you can let that child go. So concerning findings in history that we would want to rule out are these. So have they been showing any signs of an inborn error of metabolism? Is there already some developmental delay? Any concerns with the environment? And that's where the first NAI comes in with non-accidental injury. So just try to take in the family dynamic. Any tobacco or drug exposure, any social concerns, any previous or exposure or presence of an infectious or respiratory illness, or any inability to care for the infant. So those are concerning findings in the history. Concerning findings in the exam are these. So abnormal growth, any craniofacial abnormalities, abnormal vital signs, signs of abuse or trauma, and we all know what to look for to rule out child abuse, abnormal skin color, abnormal pupillary response or retinal hemorrhages, abnormal tone or responsiveness, or any other abnormal findings. And this just emphasizes the fact that you really need to do a full head-to-toe examination. So it's not a quick focused history and exam. No, this is a detailed history, a detailed physical exam where you're examining every inch of that little baby and trying to figure out what's happening. All right, so that's why it has to be very, very thorough. All right. So any baby who does not meet the low risk factors that we just mentioned is by exclusion now a red. You've got red flags, and that patient is high risk. So just the opposite of what we just mentioned. All right. So how do we manage a low risk? So what you need to do, you need to educate caregivers. We just had a very long discussion about shared decision making with parents, and this is something that is sometimes challenging with some parents, and I notice it myself between practicing in Canada and practicing in Egypt. But we need to try and introduce autonomy and the shared decision-making model with parents, with children, of course, if they're capable, and if they're too young, then with their parents. So you would explain to them what you're thinking, why we consider this low risk, and make sure they are also comfortable taking that patient home and they don't have concerns about what to do for next time. And some resources that can be given is offering them CPR training if they are interested. So that's what you should do. Things you should not do is full lab work, lumbar puncture, that full septic workup that we love to do for all patients, and then include chest x-ray, EEG, echo, check for GERD, to send them home with cardiorespiratory monitoring, or even consider an acid suppression test. So we don't need any of that. You might consider a 12-lead ECG. There is some evidence that a 12-lead ECG will pick up some of our of underlying arrhythmias. You may consider pertussis testing if they have not been immunized and you're suspecting that. And you can do some brief monitoring inside the hospital for a few hours. And again, things that you really do not need to do. So these are like black and white. You should do this, you should not. These are sort of the grayish area. So you may do these. You really don't need to do those, but if you have concerns, you may consider keeping them under some more observation and doing some more basic tests versus these more invasive ones. All right, so back to the case that we discussed. The patient can safely be characterized as low risk. They were just above the 2 months. After a thorough history, you decide to observe your patient, continuous monitoring for 2 hours, and you defer all additional testing. You feed the child, observe post-feed, everything is fine. Again, that shared decision-making is very important. Parents need to understand what's happening and make sure they're comfortable taking their child home. And the child continues to be well appearing, so you ensure follow-up and you've given the patient's parents proper education and return precautions. So just some take-home points. So we're sort of done with the ALTI and Hello to Brew. That's what we're using now. And the new American Academy of Pediatrics definition shifts it from a caregiver perspective of just being life-frightening to a clinician-based perspective. And this should help with confusion. And you want to remember that the Brew definition excludes patients who are symptomatic. So, but by the time they arrive, they should be healthy, or if there's an explanation for the event. And the whole shift, the whole point of this is to prevent unnecessary diagnostic workups. So it helps us identify low-risk Brew patients and avoid a prolonged observation period. All right, so that was my first case. Let me check our time. I think we're doing okay for time. I'll try to get another case done if we have time, Dr. Sam. Is that correct? Sorry, I can't hear you.
Yes, we have 10, 15 minutes more.
Okay. I'll try to get through at least another one. All right. So case number 2. This is a 5-year-old struck by a car, came into the emergency department with vital signs except for some sinus tachycardia. GCS was 14/15. You see a humeral fracture and multiple deep lacerations. So we know what we need to do, general anesthesia, and fix those injuries. However, the parents refuse general anesthesia. So what do? We decide to do local anesthesia, so some nerve blocks. After we do the nerve block, by a few minutes, the patient seizes and loses consciousness. So differential diagnosis, a lot of things will come to mind. One of them is like, is he bleeding out somewhere else? Did we do something wrong? This is not a very common condition. I've only seen it twice in all of my pediatric critical care years. But the interesting diagnosis here is local anesthetic systemic toxicity. The short term for it is LAST. And the major incidents, usually the major LAST events are usually very low. So here our patient seized and lose consciousness, but sometimes it can also be associated with cardiac arrest. So it is a relatively, there is a relatively low incidence, but the protocols, at least like I know here at McMaster and surrounding areas, is if somebody is giving any local anesthetic, you need to know about the complications, you need to be ready for the complications, and we'll discuss what ready for the complications means. All right, so moving on, there's been a decrease in it, and there's, first of all, because of increased awareness and some preventive measures. So most regional anesthesias are ultrasound based, so at least you know where you're going, but you're always worried about, even if you're in the right area, if you get anything into the bloodstream, that is how that systemic toxicity happens. All right, so this is primarily how local anesthetics work. So they focus on the sodium channels, which is the whole point, to impede pain transmission from those neuronal cells to the cerebral cortex. So what happens when toxicity occurs is that they affect the cardiac sodium channels and the neurons in the brain. So in this case, it was an unintended intravascular injection. Another mechanism is systemic absorption. So if we're giving larger amounts, or it's a prolonged procedure and we need to give multiple nerve blocks, systemic absorption could happen. But because this happened right away, if it had been an older patient, they might have mentioned, and this is usually a very good clue, that they have a metallic taste in their mouth. They should not be tasting anything because it should be local. But if they mention that, that's one thing when you start worrying, whoops, have I gone into it might not be a whole artery or vein, an arteriole, a venule, usually not capillaries, but usually an arteriole or venule. So we talked about unintended intravascular injection, systemic absorption, and some risk factors are extremes of age. It's a lot easier to cause that. If they have any underlying cardiac conduction disease or ischemic heart disease, any renal dysfunction, whereas that even a small fraction that has been that has gone into the intravascular system may not be cleared, and the same for hepatic dysfunction. There's no explanation, but pregnancy is also one of the risk factors, as well as carnitine deficiency. Highly vascular block site is self-explanatory, so that would be just because there's a higher incidence of intravascular injection there. All right, so safe injection techniques. I won't go into too much details, but one thing that I have found very useful are actually the last two or three. So incremental, sometimes that's the usual technique, but sometimes if you're doing an emergency procedure, you can even go longer than that, like maybe even a minute to a minute and a half between injections. And as you're making sure that you're not going intravascular, aspiration, just like even we do with an intramuscular injection, that's what you need to be, or a bursa injection, you always want to aspirate. Intravascular markers. So adding epinephrine has two benefits. The first one is you'll see that heart rate going up before you see the absorption of your local anesthetic, and that would mean that yes, there has been some intravascular absorption. And the other thing that epinephrine is useful for is that it causes local vasoconstriction. So even if there is a little bit of absorption, it reduces it. And this should have been another bullet, but of course, using ultrasound. All right, so back to this case. I think I'll stop there just in the interest of time, so I don't go over time. But how do you think we would manage it? Any thoughts? I know we don't have a poll here, but the way that it's managed is very interesting, and it's by intralipids. So the first case that I saw, I walked into the resus room and they were giving those intralipids. And I was thinking, like, is this part of TPN? Or are we giving TPN to a patient who is in a shock state? And then it turned out that they were giving intralipids because it will bind the bupivacaine or lidocaine that you've given, and it prevents release of them to the tissues. And the most important tissues that we worry about, as they mentioned before, are cardiac as well as the brain tissue. So that is the end of the second case, and I will stop that there. Thank you very much.
Thank you very much for Dr. Mona for these few cases. Thank you very much. Thanks a lot. I haven't seen any questions in the chat, but this isn't the gray area that it's important to differentiate between normal and the other life-threatening events, and we shouldn't do much for the normal.
Right. Exactly. So if they're low risk, just observe them, and education of parents, when they should be concerned, when they should come back, when they shouldn't come back, when they need an emergency visit versus just going to the office, to the clinic.
Okay. Thank you very much indeed. Thanks a lot.
My pleasure.